This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, this is Halley Alexander with the Neurology podcast, and today's episode is about an important topic for neurologists that comes up a lot in clinical practice, which is anti-seizure medication withdrawal. And we'll be talking specifically about the patient's perspectives to help inform these conversations. So with me today is Sam Terman from the University of Michigan to discuss his recent work on this. So Sam, welcome back to the podcast.
Thank you.
We talked with Sam before on the Neurology Minute regarding predicting seizure outcomes after epilepsy surgery, and we can link those in the show notes. But back to today's topic, in your study, you spoke with patients with epilepsy from 3 different centers and collected qualitative and quantitative data regarding their risk perception, tolerance, and counseling that they either have received or would like to receive about anti-seizure medication withdrawal. So what were your findings?
Yeah, there were many interesting findings from this study regarding those 3 topics that you mentioned. First, we started with seizure risk perception. We asked patients, what's the chance do you think that you're going to have another seizure if you continue versus if you withdraw medications, as that's a critical input to deciding whether you would remain on an anti-seizure medicine long term. And patients had, unsurprisingly, a high confidence in their anti-seizure medication's effectiveness. In fact, so much that about 30% of patients believed that ASMs were being perfectly effective. It was impossible to have another seizure. And they cited reasons such as physician counseling or personal experience, plus or minus an unsuccessful withdrawal attempt, including some that have had intracranial surgery even, which is great that patients are so confident in their anti-seizure medicines, though, as we discuss in our article, potentially also a bit troubling given their sense of immunity. One patient frankly responded that they had, quote, never thought of it that way, suggesting that they hadn't actually considered in the past what's the chance on versus off medications. I think this probably suggests the need for better physician counseling to ensure that patients' expectations are tempered either way and more aligned with their best estimated risk from the data that's available to us. Most people were quite cautious about anti-seizure medicine withdrawal, where about 3/4 said that they would basically never withdraw point blank when we asked them in an open-ended or multiple choice format. But I think the interesting thing was that although people gave that initial response, then we went through a series of, well, okay, if we phrased it in different ways, so it depends on how you asked. We started with saying, well, okay, if it did nothing versus if it would have to guarantee the absence of another seizure. And people actually gravitated towards, okay, no, a medication would have to guarantee I would never have another seizure for me to stay on it. Why would I be on a medicine if there was still a chance? But we pushed people a little bit farther and farther. We asked, okay, well, I hear that, but maybe what relative risk reduction would you take? And people were a little bit more cautious. Okay, maybe 40, 50, 60%. And so they started to open up to, okay, maybe there's a chance that I would take and I would still be on the medicine. We phrase it, though, in terms of time. Okay, so getting away from probabilities, which people have difficulty understanding probabilities, especially patients with lower numeracy. And we said, okay, well, if a medication pushed back the next seizure, you knew you were going to have one, how much time would be enough for you to be excited about being on a medicine? And they said, some patients even said a day, a minute, an hour. And so that's such a far cry from it would have to guarantee a seizure. And then we said, well, if you knew you would have one, but it would reduce the severity, maybe you would be less convulsive or shorter. And they said, yeah, I would still. So people kept on scaling back depending on how the question was phrased. So I thought was very interesting. And finally, we gave people actual numbers. We gave people pictures called pictographs, which are visual depictions about the chance of an event happening in different scenarios. And most people were pretty conservative of the higher risk, but people actually did change their decisions depending on what risks we showed them. We showed people a 25 versus a 50% chance, which is kind of that higher risk scenario, all the way down to a 10% versus 11% scenario. And I think that 10 versus 11% scenario was the most interesting. You had some people that said during the conversation, oh, I would never stop my seizure medicine. And then we showed them that 10 versus 11% scenario, and they said, that's about the same. Yeah, I think I would come off if that was the risk. But on the flip side, some people went the other way, where there was a patient that was planning on coming off after some future minimal seizure-free period. And then they said, oh, wait, when they got to these pictures, they said, oh, wait, so you're saying there's a chance. And so they kind of flipped based on whether it was a verbal conversation like we might have in clinic, as opposed to whether we were actually showing them, quote, concrete numbers. And then we asked people, well, these are hypothetical scenarios. What if we had a decision aid that could capture your individualized risk tailored to you and your risk profile? Would you like that? How would you use that in practice? And people were very receptive to receiving such numbers. They felt like it would help them. But people said, I've never gotten such numbers from my physician. I would like them, but I've just never received this level of detailed counseling numerically. And so in summary, there are many components to this article where we explored elements of risk perception, risk tolerance, and what sort of counseling, as you said, people may not be getting but would like to get in the future.
So I'll just clarify, when you're talking about the options you were presenting them, 10 versus 11%, you were offering, if you had a 10% chance of having a seizure on anti-seizure medication versus an 11% chance of having a seizure if you stopped your anti-seizure medication, correct?
Correct.
Yeah, and it sounds like there were maybe some contradictory findings, which is not specific to people with epilepsy. I think this is similar to behavioral economics for how people, for example, manage money. They don't always make the most rational decision. There are other factors that come into play. So it's really important study that you did to try to start untangling what factors weigh into the patient's decision making. Now, in my experience, it's the driving impact that often influences the patient's ultimate decision about withdrawing anti-seizure medication. Just how that would, if they had another seizure and they weren't able to drive for 6 months, how that would impact their life and usually results in them staying on the medication. So I'm just wondering, did driving come up in the discussion at all?
Absolutely. Driving came up as a critical factor for many patients. Some weighted it quite strongly. Some rationale surrounded independence, but it seemed like through the qualitative interviews, the stronger rationale was they don't want to kill people. They don't want to crash their car. It was more of a safety rather than an independence factor, but it was a mixture. However, I should say that other people weighted it much less strongly, which is the role of individualized risk-benefit analysis and probing the patient's psychosocial situation and their individual needs. Some patients would not drive anyways. We included some patients that had surrogate decision makers, patients with static encephalopathy, some patients that are older and have cognitive impairment, other patients that work from home. We live in a post-COVID area where a lot of work and grocery delivery can even be, at your door or work remotely. Patients sometimes have public transport or have a spouse or have a friend. So this appears not in this specific manuscript, but in a companion manuscript that we also have under review, where this was just one of many factors that people cited. People also cited side effects and fear of long-term organ injury and the inconvenience of medications and the degree to which they think their intracranial surgery, quote, cured them of their epilepsy, their risk perception. Their belief in complementary and alternative medicine came up sometimes. They're concerned about if they had a seizure, how serious would that be? What kind of injuries? And not unlinking it a little bit from driving. Their family support, their supervision. And we are even in the process of writing up a manuscript regarding patients who have had a seizure after they have withdrawn medicine. We asked them, what did you think about that experience looking back? And most patients actually talked about the knowledge that they gained from the attempt, which makes sense, but maybe not exactly what we were expecting, kind of the knowledge, the experience. So I'm glad I tried that. Not going to try that again, maybe. But so driving is so important, and yet it was just one element in this complex milieu of many patient factors cited.
That's a good point. Now, you mentioned that patients really wanted numerical estimates, actual numbers, and as specific to their personal situation as possible. They want that presented as part of this counseling conversation. But our current American Academy of Neurology practice advisory on anti-seizure medication withdrawal says there's no evidence to support the use of online seizure prediction tools at this point. So just saying there's not enough evidence to support it. So in that environment, how can we best navigate this conversation with the patients? How do you go about trying to give some sort of numerical estimate?
It's phrased as no evidence, and oftentimes, although I'm personally not a guideline author, this time guideline authors likely are cautious in terms of providing recommendations unless it's based on firm evidence, the best is double-blinded randomized controlled trials. There are not, in terms of do online risk calculators affect behavior, affect the chance of seizure, relapse, affect long-term outcomes. So I recognize that, although I probably qualify that, though I think no evidence is probably a bit incomplete because we do have evidence. The online seizure risk calculators that do exist, and there are many, well, at least a few that are relevant to this topic, they're based on large samples from many cohorts with development and then internal, external cross-validation. It has many rigorous components to develop an accurate seizure risk prediction. Now, I fully recognize that the predictions that are provided are imperfect. They lack some important covariates. The external validation has been imperfect. Some of the covariates that are in there are maybe not measured as quite accurately as we would have liked, or using updated ILAE terminology as we would like. So it's this balance. I would also say that through our own work, we have done other work where we provided an electronic survey to over 300 international neurologists, and we gave people an experimental vignette where we asked neurology physicians for their recommendations before versus after giving these online prediction tools. And we were doing that. Clearly, double blinding is not possible in this particular context about whether you give people information or not. But we saw what was the delta and how did physician seizure risk estimates compare to the predictions, and also how does giving predictions affect behavior. And what we found was that giving physicians the information sometimes made little difference, but if anything, it made physicians more cautious, particularly in those cases with a normal EEG, where it seemed that the physician felt more reassured than the calculator was, due to perhaps overemphasis about a single variable rather than multivariable thinking. There was another study in the 90s that did this for patients. There was an older study called the Medical Research Council Anti-Epileptic Drug Withdrawal Trial, which is a 1,000-person trial in the 90s across the UK, where they randomized patients that were seizure-free to drug versus no drug, or withdrawal versus not withdrawal. And they developed a calculator and a follow-up study where they gave patients the calculator and not. They did the same kind of crossover that we did with physicians. And they also found that giving risk estimates made patients a bit more cautious about withdrawing. And I would say, well, although we do not have current randomized data in terms of the effective calculator, and the calculators are imperfect, I would say, well, what's the alternative? The alternative is a imperfect, human-based, GIST-based, in-your-head, multivariable risk calculation that, time again, data have shown may be less accurate than data-driven risk calculators. I would further point towards evidence about in hypertension and lung cancer and other situations where it's been shown that treating patients according to computed multivariable risk estimates is superior to treating patients based on any single risk factor alone. And there's a clear analogy in terms of the cardiovascular risk factor. There was the Framingham risk calculator, and then now there's the pooled cardiovascular cohort equation. So that's very much in common use due to the acknowledgement that a well-developed risk calculator may be a rational way of choosing patients for therapy versus not. So I see the point, although I would qualify that because we do have some data.
Yeah, and I like the point you made that the online calculator might not be perfect, but neither is the human physician, who also doesn't have a perfect way to predict the patient's risk of seizure recurrence and is also subject to bias. You do talk about that in your paper as well. They had a patient recently who came off meds and had a seizure that ended them in the hospital or something like that. They're going to have that availability bias and potentially counsel the next patient differently. And at least with the online tools, they're not as subject to those sorts of biases. So the combination of the expert clinician and the online predictor tools at this point is...
I think the key is the combination of the physician's judgment, the patient's experience, and the best available data that we have. Because availability bias, as you mentioned, it's a matter of if you ask someone what's the chance of something happening, someone can say that, well, people can confuse the probability with the severity. So if something was really severe, they might overestimate the chance of recurrence just because it was severe. And so it's not wrong. The word bias, it's a loaded word, although that's how it's framed in the cognitive psychology or economics literature, that we have these biases, framing bias and availability bias. And it's not wrong to reflect on your experience and think about the consequences, but we do try to isolate each component individually as much as possible in our work in terms of the consequences versus the probability.
It's an exciting time in the field because it does sound like we're moving toward having better tools that would be similar to what they've developed in cardiology and other fields. Now, related to all this, so taking it all into account, how should we approach this conversation with our patients? Meaning, like, when should we have it? What talking points should we bring to the conversation? And how should we present numbers, if any?
Your first question about when, we actually asked patients this question, not in this specific manuscript, but in other areas of our semi-structured interview script. And we asked the question, should the topic of duration of therapy be addressed early on, right when you're starting a medicine, or should it be pushed back towards a later time? So there are arguments either way in terms of when you start a medicine, a lot's going on. There's a reason that you're starting the medicine. Maybe they just had seizures. Maybe their circumstances changed. They're seeing the doctor. They're getting a lot of information, being overloaded with a new diagnosis and new therapies and new daily routines. So you could argue, well, we're just going to talk about starting the medicine and what side effects you could expect, and this is when you should call me. So don't overload the patient. But on the other hand, I think it's also good to set expectations. The patient who doesn't have expectations, and if you don't have any parameters, the patient has never heard of this before, it might come as a total surprise, and you might just have a very different conversation if you haven't planted that seed, for better or worse. And so it's a two-sided hypothesis about what should you do. Patients were not uniformly in one direction or the other. So I don't think our study can provide clear guidance on timing. And so it's an individual decision, I would say, without a clear conclusion. But in terms of more broadly, how do I approach these conversations based on what we learned? So I probe their thoughts to prime them about a conversation. I think about, before diving too deep into should you come off your medicines, I say, what do you think is good about your medicines? What do you like about being on medications? What's bad about being on your medications? What could be better? What type of a person are you in terms of maximizing or minimizing your medical care? Are you the kind of person that wants everything or just wants things that are felt completely, totally necessary? And where do you lie when things are in that gray zone? Do numbers help you? And critically, in terms of decision psychology, there's this piece that, do you feel there's a decision to be made? These decision cognitive biases, some of these things, some of these components of counseling maybe are not even relevant if the patient says, look, there's not even a decision here, or it's not even my decision. Whose decision is this? So there are all these preparatory things that sometimes we don't think about as much that I think are important for setting the scene. And then thereafter, I admit, despite all this research, this line of inquiry about quantitative tools, I'm guilty about a qualitative approach, at least to start. And so I say, my job here is to equip you with the information, the insight, and give you the gist as the first pass. So say the best case is you've only had a few seizures. Some of these episodes I'm not even sure are seizures. They were a long time ago. You have a normal EEG. I don't see a structural lesion on your MRI. Your dose is already low. Maybe they're already missing doses anyways without breakthrough seizures. Even when you got sick that one time, you didn't have a seizure. Maybe you can get by without driving because of remote work or public transit or a friend and such. And even if you had a seizure, then you may not have to wait the full 6 months, because sometimes during a medically supervised wean, the duration of driving restriction can be shorter. You wonder if your medicines are causing you problems. You're the person that maybe doesn't want to take a medicine if you don't have to. You have a partner, you have some supervision. And so all of these things go into this. After going through all those pros and cons, I then often say, you're in a really good position. You're in a position where you haven't had seizures. Most people that have persisted on medications this long feel like they have reasonably tolerated them. I tell the person, there's no urgency. Let's talk about this. If you're ready, fine, we can make a plan. If not, we can always reevaluate. So sometimes it's an ongoing conversation that spans numerous visits. Within a visit, you ask, how do I give numbers, or do I give numbers? I would say if I give specific numbers, I try to do a few things. I try to make the time course clear, because if you say there's a 20% chance when in the next second, minute, hour, year, decade, I think it's important to clarify that. I give absolute rather than relative risks. It's well known that people respond differently. Relative risks can seem larger than absolute risks, and yet absolute risks tend to be more interpretable. I include a comparison, so you can't just say there's a 50% chance off medicines. You also have to include there's a chance on medicines, and also acknowledge the uncertainty around such estimates that I'm giving a patient. Oftentimes also probability frequencies can be understood better than percentages, perhaps. So frequencies being like there's a 2 in 10, there's a 3 in 10. Sometimes that can be better understood than 20%, 30%, making sure that each figure has the same denominator. So these are some basic elements of, I think, good numerical communication in terms of being of specific and being absolute rather than relative. Although there are numerous aspects where I don't know the right answer. I'm not sure that currently science can tell me one way or the other. I'm not sure whether and how to apply so-called evaluative labels. So you say, you're high risk, you're low risk. Who's to say what's high? Who is to say what's low? Framing, do you frame it positively or negatively? There's a chance of a seizure or there's a chance of seizure freedom. It has been seen in prior behavioral economics work that people may be more risk-seeking if you frame things negatively to avoid risks, depending on how you frame it. And the order of risks and benefits, there's a chance of seizure reduction, but a chance of side effect reduction. All these small things, I think, make a difference. But I think what's clear is that if you give patients numbers, you've got to be specific about exactly what number you're talking about with a comparison. And then there is the question about who do you bring it up? When do you bring it up? And that's also a challenging issue. The physician can preview that number before or think about what number they would estimate their patient's chances of being before a clinic visit and use that to apply. If a patient seems to be going in the way that you don't think they should be going, you can bring that number up, or you could bring that number for people that feel like numbers would help them in your conversation or people with higher numeracy. But it's a really challenging issue about patient selection. But I hope that in our future work, we will better explore that topic about who would like numbers and how do patients process them and using different content and formatting of such numbers.
Yeah, it's a really nuanced, but also a really, really important conversation. So I'm glad you're doing this work. Are there any other changes you're making in your clinical practice now based on the results of your research?
One message is that patients are cautious about withdrawal, which is not really a change in practice. It's maybe a reinforcement of, I think, how I often counsel patients and how patients also discuss with me. I think one change is you can't assume knowledge. It's never safe to assume that a given level of numeracy or a given level of understanding, if you give information about this is what I said, well, what did the patient hear? And so maybe that kind of teach back moment about what do you understand based on what I've said about your seizure risks and the pros and cons of being on seizure medications. And also that knowledge about that there is a chance that you could have a seizure on or off of medications. And so while people can have a legal privilege to drive, they are seizure free for at least a certain number of months, depending on the state, still emphasizing that, look, although you're in a good position right now and things are going well, I still want to make sure that you have realistic expectations that there's still a chance, even if it's low, that you could have a seizure on medicines. And so even if you're taking this medicine, if you're sick, if you're sleep deprived, if you do happen to skip a dose, do be cautious. It's still a good idea to have a buddy and make sure that someone understands the situation. I probe a person's so-called minimal clinically important difference about what do you think would be enough? What would a medicine need to do for you to say, I would like to keep going? And this work has shown that there may not be a single answer. It really depends on how you phrase the question. And people might respond one way if you ask in terms of relative risk or absolute risk, and people might have a totally different response in terms of time or visual depictions. And so sometimes I ask the question in multiple ways to try to get a deeper understanding of the patient's perspective. Maybe this is less in terms of clinical practice, but informing my future research is that, as I mentioned, we really want to understand who wants information, who should we target with information, and what seizure risk threshold does evidence say is really high versus low, or would suggest that someone has net benefit versus harm to withdrawal. There were many counter arguments to the seizure risk information. And some people, we asked what seizure risk would be too much, and they just looked at us puzzlingly, and they replied to us that it's in God's hands. This is not a numerical decision. It's not even my decision. It's just a very different way of thinking compared to this risk calculator that we are looking into. There was also people that ascribed to the numbers, but they mistrusted the number as inaccurate. They thought that a doctor who gives you the number might be, quote, doctoring that number to either inflate that number or deflate that number to get the patient to do what the doctor thinks they should do, which is a really fascinating product of this research about the trust. And even if a patient trusts that the doctor is giving them their best number, there's still mistrust about the accuracy. And some patients who believe the number is right, they still wouldn't change no matter how low. So there's a lot of nuance. And so this all directs our future research thrust. But clinically, how does it change my practice? Some of what I heard may be a little more enthusiastic to give people numbers and engage in that shared decision-making process that way. It's also made me understand the caution that a better decision doesn't necessarily rely on having more information or harder or more numerical information. So it really depends on the person and what they're looking for, what you think they need to make sure that they have the knowledge necessary to make a decision that's concordant with their values.
Those are excellent points. And of course, there's always the patients too who will say, that they don't want to decide. They'll say, well, you're the doctor, you tell me what to do. So there's another factor too. But to summarize the excellent points you just made, starting by asking about the patient's, priorities and goals, what's important to them, doing that kind of qualitative digging. You talked about having them teach back because people can perceive numbers and risks differently, even by when presenting the same information. So having them teach back what you said, I liked that point as well. And then the final point I'll summarize is presenting the information in multiple ways can be helpful as well to help the patients. As you've shown in your study, they kind of change their mind when given the information in different ways. And so presenting it different ways can be helpful as well. So thanks again, Sam. Our listeners can find you and your colleagues' article, which is titled Patient Perspectives on Antiseizure Medication Discontinuation in the Journal of Neurology Clinical Practice.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.